Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yep, here we go again, and thank you so much for choosing to spend a little time with us. We know your time is valuable, and so is ours. We want to make sure that you're part of the deal here, and Dr. Juliff's clinics, 4 of them here in Hawaii, on the Big Island. This is actually where it started, on the Big Island, and Maui and Kauai, and now here on Oahu. And we are recording this on Oahu Island. We have over the last several months covered a whole bunch of stuff, and sometimes it's really easy to see what's going on, and sometimes it's not. But there is a real interesting path that Dr. Juliff's going to help you with as we go down and define the types of venous diseases there are, and more important, where do you fit on the pie chart? Is it going to happen to you? And if so, what can you expect in the way of treatment? So, that being said, I guess maybe it's one of the easier programs that we're going to be able to share with our audience, Doc, and that is because there are some real primary things and some things that are a little bit more serious about venous disease. Yeah.
And that's what the 2 large kind of subcategories of venous disease is. Just as you stated, primary and secondary. Is it the primary problem, or was there another problem that then led to your venous system being adversely affected? But a lot of people want to know how common venous disease is, and
more importantly, if I've got it, where in the pecking order am I?
Or how likely am I going to have? Is it going to be that I get it? But unfortunately, venous disease is very prevalent. There's probably 30 million Americans at any one time in this country that suffer from significant venous insufficiency. That's a lot of people.
Yeah, that's like, it used to be, we say 10%, but it's in there. It's certainly near double digits.
Right. And but the unfortunate part about it is that even though there's these 30 million people out there that have significant venous disease of one sort or another, there's only about 1.9 million that actually seek treatment.
Oh my!
So
the rest of us live with it.
There's a lot of people.
Wait a minute. I want to say the rest of us. The rest of them, because I get treatment.
Right.
And maybe it's just because they don't even know they have it.
Well, they don't. That's a big part of the problem. And that's one of the problems that we fight all the time is trying to educate people and other medical providers of what the common signs of, because it's not always obvious. But so of those 1.9 million people that get evaluated, only about 25% of those are completely evaluated and treated. So, it's just a small fraction of all the people out there that have venous insufficiency that are actually getting, full evaluation, full treatment. And that's a shame. It's a shame that that's the way it is.
In this day and age of specialization and everything, and, you certainly are a venous surgeon, you are a specialist into it. I'm imagining that a lot of these things are done by the country doctor or by the GP, and maybe aren't recognized as being something that really needs to get treated because there may be no symptoms, just little this, little that, but no problem.
Mm-hmm. A lot of it is either one of two different things. They see and recognize the problem, but they don't connect it with venous disease, necessarily. They hear the symptoms, but it's not, commonly connected with a vein problem. Or they're not recognizing what they're seeing, and consequently it goes nowhere. But unfortunately, a lot of complaints of the legs just in general, but especially as it pertains to venous disease and venous insufficiency, people do ignore it, and you can get by doing that. You can get by ignoring it for a long time before it becomes a very, very big problem.
And I saw something in my notes that Dr. Juliff gave me, and I do want to remind you, and I'm going to do that throughout the show, that you need to go check us out on the web It's veinclinicsofhawaii.com. Veinclinicsofhawaii.com. And later on, I want you to write that down later. Later on, I'll also give you a telephone number. One of the things that popped out of me from some of the notes that you sent me were that other countries, I'm not non-Western countries, they don't seem to have as much of a problem. So my question is that true? And if so, then does that suggest that our lifestyles might have something to do with some of the chronic disease that we get in circulation?
That's probably part of it. Yeah. Most non-Western countries in general, I mean, I think the people are probably a little more active. Often their occupations have more to do with physical exertion and physical activity. But on the other side of that, however, is that much venous disease is basically a genetically inherited problem. So it's it's in our genes, and since people in one region of the globe have common genetic makeup, a good part of it is that too.
When some people see some of the writings that pop out, maybe every now and again they're sitting in a doctor's office or dentist's office at the barber, and they look at a magazine that's about venous disease, and they'll say that there's another stat here that I want to ask you about. In the industrialized nations, which we are certainly one, 1.5% of people will develop a venous ulcer. And you say, man, that doesn't sound like very many.
Yeah.
It's a lot.
But it's a lot of people.
Yeah.
I mean, when you think about that number, 1.5% of the adult population of this country, developing an ulcer of the lower leg. We're talking about skin breakdown
that doesn't heal right away, or maybe ever.
Yeah, may not heal ever, or maybe it is a sore that it takes many, many weeks to get healed, but then comes back or whatever. But 1.5% of the adult population. That's a lot of people. Now, if you tack on that, if you kind of insert age into that, after the age of 65, that frequency jumps up to 4%. Now, if you're talking about 4% of all the adult population over the age of 65, that's a lot of people.
Millions. But by the way, what about just our life expectancy? In the Western countries, we seem to be, thanks to or because of medicine, keeping ourselves alive a little longer than some of these other places.
Yeah, actually, along those lines, I just recently heard that a woman in this country right now, once she reaches the age of 65 and is relatively healthy, her life expectancy actually is 93.
That's amazing, isn't
it? That is.
Now, they say that this generation, the next generation, is the first one that's either going to be leveled off or decreasing. You couldn't keep thinking that it's going to keep going up. But there are some people that are comfortable with 100 now.
Yeah.
And that's pretty impressive.
Well, and some people think it is going to keep going up. It's hard for me to conceptualize that.
But the argument would be, they'll keep us alive a lot longer, but what's the quality it's going to be?
Yeah.
And so somewhere you have to decide, do I want to be 118 or would 103 be enough, Anyway, but I think it's interesting because aren't we all creatures of, curiosity? Don't we want to see, okay, where am I in this big picture? My mom had ulcers or bad veins. My mom did. Thanks, Mom. I got them.
Right.
And so are you saying that that's another part of it? Because it seemed to be, blame it on your folks, genes.
Yeah.
And maybe some of these other countries' genes don't have this element in it.
Well, and that's just it. I think that's why there's sort of a global variation. Some countries are a little more prevalent than others, and I think primarily it's because of genetic makeup. But I think physical activity also I think impacts that too. Definitely. But, getting back to the separation between these two large categories, we've talked about staging of vein problems before from a clinical standpoint. And we've talked about, class 1 through class 6. But a little different way to look at that is some amount of venous disease is considered primary. Some of it is considered secondary. And by and large, the majority of people have primary venous insufficiency.
Okay.
And probably 70 to 80% of people that we see with venous insufficiency, they have what's called primary venous insufficiency. The other 20% or so have something that's called secondary, which means that it comes about because of another problem. But what are the common features of all venous insufficiency, whether it's primary or secondary? There are common features that we see. And, the veins are blood vessels in our legs that carry blood back to the heart. Veins in our body all over carry blood back to the heart, but veins in our legs have to carry blood back up to the heart, in an upward fashion against gravity. The way that happens is because there are many, many little one-way valves in the veins to keep the blood moving up. Those one-way valves are sort of check valves. It allows the blood to go up, does not allow the blood to go back down.
In a perfect world, when they're all working, you wouldn't be seeing me as your patient.
Exactly. Yeah.
Dang.
So in a perfect world, when all those valves are working, there's no problem. But valves fail, and that's we'll touch on this a little later. But often that's a genetic thing, and that's what we call primary venous insufficiency. But all valves fail, or as the valves fail, blood starts to settle downward into the leg, and that's what then creates the symptoms that we see.
I hate to use an automotive analogy, but you know me. You take your car, and back in the day, we'll just go and clunkety, and they say, well, you have a valve problem. We're going to do your valve job.
Yeah.
We're going to change your valves.
Yeah.
The only thing that I've learned in all of these years, and certainly since you and I have been doing this program, is that you're darned if you don't, but there is no fix to the valves yet. I mean, I'm sure someday your profession will come up with a little pocket full of valves. Here you go, Doc. Go ahead and put them in.
Yeah.
But until that time comes, what do you do when these things fail?
Well, we will touch on that. The basic problem, the thing that we have to fix, and you're right, those valves that are in the veins that we commonly work on, they're tiny little pieces of tissue. I mean, they don't really even have a lot of form unless you really look at them microscopically. But they're so small.
Yeah, I've noticed this. Not only they're so small, I've seen them sort of on an ultrasound, not the valve itself, but you can see when the blood rushes, because when you restrain it and then you let it go, it's trying to go somewhere.
Right. Yeah.
And it's going through a valve which may or may not be working.
Yeah. Well, which often, if you're looking at that ultrasound and you're seeing the blood go in the wrong direction, which is the thing that we look for, then the valve is not working. So the valves fail. Blood starts to settle down into the leg. That's something that we call pooling. And as that blood settles into the leg, again, that's what creates the symptoms. Now, I often get asked, well, what's going on there, Doc? Because, I mean, if the blood is going down and it's not coming back up, then what, doesn't your leg just get bigger and bigger? Because
eventually,
all the blood, But it's kind of like the venous system in the leg, it's kind of like a reservoir. And, it can hold a certain amount of blood. It's capable of holding a certain amount of blood in a, normal sort of situation. But as the reservoir sort of fills up, then blood starts to come back up the leg, based on activity, muscle action, all this sort of thing. But in venous insufficiency, there's too much blood in the reservoir. And as that reservoir, fills up, that's when the problems start.
Yeah, when we talk about this, we're getting into the symptoms here. When we talk about that, one of the biggest signs is swelling. But you've said before that swelling in the leg can be indicative of a lot of things. You have to go through a really interesting process of elimination before you decide this swelling is because of venous insufficiency.
Right. Yeah. There's a number of different things that can cause swelling. And we have to, if we feel like it's due to venous insufficiency, number one, we have to show that. And then often we need to do whatever we have to make sure that it's not due to some of these other things that, might cause swelling. But, the other thing is that, blood is filling filling up the lower leg and creating this pooling and the reservoir is filling. But also what's happening is that there's an increase in pressure within the venous system, something that we call venous hypertension. It's kind of like having hypertension of, just regular hypertension. Although, however, that has to do with the arterial side of the circulation, the heart. The other parts of the heart,
that's the big old. By the way, I've learned through Dr. Julep, lucky me, there's no valves in the arteries. They don't need them.
No.
Because it's going downhill.
Right.
Now it's the veins' job to bring it uphill. They got the valves.
Yeah. The arteries have the heart. So, the heart is pumping and the heart pumps and blood goes through arteries. Veins don't have a heart. There's not a heart at the other end of the veins that are shooting it back up. But so what are the symptoms? Well, the usual symptoms are pain, achiness, fatigue, heaviness, muscle cramping, throbbing, rashy, changes of the skin, something that we call venous eczema because it looks a lot like eczema. And the other feature of this is that which kind of delineates this or separates it from other causes of these pains is that these symptoms will usually get better with exercise.
Okay, now it seems to me that most everybody listening, if they're over 20 years of age, are experiencing some of these symptoms. Now, it may or not be for venous insufficiency, but that's a long laundry list. I mean, that's a lot of things. So I would imagine that the more of them you have, it must be easier for the practitioner to sort of determine what's going on here. And maybe this pain or itching or heaviness or whatever is really a good sign, because if you hadn't had that, you wouldn't know or think there's anything wrong with what's going on.
Sure, they are signs.
Yeah.
They're signs and symptoms that lead the patient to wonder if there's something wrong and seek out a remedy.
Why does the symptoms get smaller when you're able to be more active?
The part of we were talking about the fact that arteries have the heart that pumps blood through them. The veins don't. They don't have a heart. However, it does. Movement of blood through veins is reliant on muscle activity especially in the leg.
So get that muscle in good shape, in other words.
Yeah. And it's something that we refer to as the calf muscle pump, which the muscles of our calves contract, and that actually pushes blood through the venous system, so that keeps the blood moving.
By the way, I saw a guy the other day, and I thought, wait till I get Dr. Julep in the corner and ask him this one, because we talked about it before, and this is a good place to drop it in. This is a guy sitting at a coffee shop in the Kahala Mall, and he's got that shaky leg thing going on. And I'm thinking, you know what? I wish Doc could see this, because if there's some serious pumping going on there.
Yeah.
But that's a little different too, isn't it?
Well, it's hard to know. I mean, if somebody's sitting and a lot of people just kind of have a nervous twitch of their leg. However, there is something called restless leg syndrome.
That's what I think this guy had.
It can be displayed like that. It's often displayed in other ways. Especially if the patient has kind of leg activity that they don't seem to be in control of, when they're resting, when they're sleeping, etc. That restless leg syndrome is another way that our body is making the muscles contract and that calf muscle pump to actually come into effect.
I'm going to do a study, and I'm going to see if bigger people have the same shaking or not. And I would imagine that it's not related to size, it's just the way your leg is.
Yeah.
Okay, but interesting, and I know this phase is the neatest part of the phase of what Doc and I are talking about today, this venous insufficiency and the primary and some of the other terms that you're learning, primary and secondary, is that what I think is fantastic is the signs that you can get. So everybody can take a look. It's like an old dermatologist friend of mine used to say, check your birthday suit on your birthday. This is a pretty good idea that you better look for some of these things.
Yeah. In addition to the symptoms, then, those are the things that we feel. There are also superficial signs, the things that we can see. And, of course, varicose veins and spider veins are easy. I mean, everybody knows that that's connected with, some sort of vein problem. But that's what we look for. Getting back to, the patient and, they may have a few of the symptoms, but not all. And how do you sort through that? Well, we look at the whole picture. What are their symptoms?
Sure.
What do their legs look like? What is the examination? What is their family history? We kind of put it all together.
Gang, here's a really important thing and why you should go to veinclinicsofhawaii.com. The good news is that a lot of these symptoms or a lot of these things that Doc says present, a lot of times your primary care physician, if they're sharp, they're going to say, this guy or this gal has to go see a venous specialist because these are classic symptoms, particularly if there's more than one, that it is, why go through a lot of experimentation when you can go to right away go to a specialist and get looked at?
Yeah. It's like
we got to get that going.
It's like anything,
Yeah.
But so some of the other superficial signs, and this is something that we see a lot of just walking around, the general population, is skin discoloration.
Sure.
Brownish discoloration of the lower leg. And a lot of people chalk that up to diabetes and other things or being out in the sun too much. But often it can be due to venous insufficiency. And then there are other skin changes that occur, and, the skin can become thick and fibrotic. That's something that we call lipodermatosclerosis.
Yikes.
Sounds bad.
It sounds really bad. So I don't want that.
No.
But interesting, to me, it's interesting because of the way that you can do that. You said a minute ago, you said diabetes, and there's a lot of times when somebody that's getting a doctor's treating for diabetes all of a sudden says, hey, wait a minute, there's something else going on here. It's not just diabetes. There's more here in your leg.
Right. Yeah. And that's the key to, kind of be open to, other causes for signs and symptoms and try to address everything. So the skin starts to thicken. It becomes very fibrotic. And then right around the corner after that, as we've talked about in the past, possible ulceration.
By the way, when Doc says fibrotic, I've learned it's like leather-like. It gets to, it's not supple, nice, smooth, silky skin. It's like leather.
Right.
Yeah.
Exactly. Yeah. And I was talking about that issue with someone here recently, and that's exactly what I told them.
Yeah.
They were asking me, well, what do you call lipodermatosclerosis? And and I said that's what you have to do. You have to feel the skin. If it feels normal, then there's no lipodermatosclerosis. If it feels rough, thick, then it's there.
I think there's a great amount of cooperation going on between some dermatologists and some venous specialists because there are a couple of things that by process of elimination you really have to look at. So I'm imagining every now and again that you'll have to have a patient that has venous issues, but it also has to go see a diabetic doctor.
Sure.
Blood sugar problems.
Yeah. Well, a lot of different things interacting and resulting in the same thing. But so ulceration can form. That's kind of the end stage of it. But anyway, those are the common features of all types of venous insufficiency. So now let's talk about primary venous insufficiency. What makes that different, or what are the patients that we see that have vein issues that we would describe as being primary? Well, these are people that have not where their venous insufficiency occurs spontaneously. Right. There's not an inciting event. So typically, it comes on over a long period of time, slowly, and like we've mentioned, there usually is a genetic cause.
Sure.
There's the genes are there somewhere, and a lot of people come in and
I'm just like Mom. It's not much I can do about this.
Well, they say that.
Yeah.
A lot of people come in and say, "Well, no, I don't recall that my mother or my father did have anything." Well. Yeah, but often it's in there somewhere. It's in the grandparents or the aunts and uncles.
Well, I got to tell you another thing, and we've learned this, even though this is Hawaii, that there's a lot of people that they've got it. You just don't know because they are either so concerned about what it looks like that, Uncle never goes to the beach, and you never see him with slippers. He's always wearing shoes and socks, and that's because he's got either venous ulcers or she's got it. And so I think a lot of people are walking around with this, and they're the only ones that know that have it. They have
right.
it.
Yeah, that happens all the time, definitely. So, it's not unusual I think, especially if the parents are kind of an older age group. It's not unusual for their children to not have seen their entire leg, maybe throughout their entire life. So anyway, so it's usually an inherited problem. Most patients can identify family members, some don't. With respect to the likelihood, getting back, as we were talking about before, if any one person says, gee, how likely is it that I might develop venous insufficiency? Well, if you have one parent that has varicose veins or has been treated for venous insufficiency, you've got about a 50 or 60% chance of also having it.
Here comes the bomber, though. What about if you have both parents?
If both parents, which, it's surprising. You wouldn't think that there's all that many people out there where both parents had venous problems of one sort or another.
What if they met at the vein doctors? A couple of young people meet at the vein doctors.
It's unbelievable the number of romances that start in our waiting room.
There you go. But seriously, I think what you're getting at here, earlier in the program, Doc was explaining what a percentage of us get some sort of venous disease, about 30 million Americans. Now, that 30 million, if you're part of that group, it's because your likelihood of being part of that group is compounded if both sides of the family have venous issues.
Yeah, if both your mother and your father have it, then it's almost a predetermined thing. Yeah. You will likely have it, but it's about 80 or 90%. It's not 100, but it's way, way up there. But yeah, so I think this helps people because of the fact that there are so many symptoms and some signs that they may not necessarily connect with vein issues or venous insufficiency, vein disease. However, if they have a family history of vein disease, that might trigger them to realize and at least ask the question and have somebody help them figure it out.
You know what I think is a real blessing? I ran into a patient of yours who was also a listener of our show, and started listening to the show after they became a patient of yours. I mean, they already knew it. But interesting, most of them say this, is that what we're really talking about is management. You're talking about managing. A dentist manages your teeth. A venous surgeon or venous office manages your condition. It is highly unlikely that it's going to go away, particularly if you're part of that 100% group. It's predetermined.
Yeah. In that, I tell everybody that. I mean, that's a very, very good point, especially, people who come in with spider veins. I mean, it's an obvious sort of thing. I tell everybody that we're treating, we are not curing you of spider veins. Yeah. We're going to be helping manage your spider veins.
And interestingly enough, I got to tell you, gang, I've had wonderful experience with that. And I've noticed a couple of little things coming back. And it's not that you get mad at your doctor, because at the time when you look at these nice, beautiful legs with no veins on them, that doesn't mean that there's not one lurking about a quarter of an inch underneath there, just waiting for a nice day to pop out on it.
Yeah, which is another good point. You don't have to have varicose veins or spider veins or really any other superficial sign. Visual sign. You can still have venous insufficiency and have other symptoms that aren't necessarily aesthetic.
Yeah, I think that's very interesting.
So anyway, so the underlying problem in primary venous insufficiency is the valve is failing, like we talked about before. Now, why is it failing? Well, it's failing because an abnormality of the vein wall. So it's not a valve problem itself. It's more of a vein wall problem that then affects the valve. And with age or with genetics and with lifestyle sort of things, influences, the vein starts to get much more elastic. It starts to dilate. And that's due to usually a biochemical kind of change in the vein. There's less elastin, which is keeping the integrity of the vein. So the veins are getting droopy.
Okay, it's sort of interesting. When that happens, is it more likely to become worse? In other words, it's droopy. That must mean that the blood that's trying to go up is not. And that means it must stuff is dripping down on it. That's what this pooling is all about, droopy veins.
Right,
Yeah.
right.
Yeah.
Well, yeah, the veins droop, and drooping is a problem with age in a lot of different parts of our body.
Yeah.
Unfortunately,
People look at their eyes, boom, they go get those fixed. They don't want droopy eyes.
Yeah. So as the veins start to dilate, become droopy and dilate, then that's when the valves fail, and that's when the blood starts to settle down into the leg and starts to create its problems.
Interestingly enough, and Doc has explained this before, but maybe a quick mention, that we talk about the legs all the time. You have veins and these things all over your body, but just because we are standing up and erect, most of the problems come from certainly from the waist down, but even from the thigh down.
Right.
Yeah,
that's true.
Yeah.
It's we get that question a lot too. Well, I've got all sorts of these veins that you can see on my arm.
Yeah.
Is that abnormal? Is there some kind of pathology going on there? And the answer to that is, well, no.
Yeah.
Usually there is not. However, if we walked on our arms, on our hands all the time, that probably would become a problem.
I would say they'd become a problem, sure.
Similar to the
and that
legs.
leathery skin would be real prevalent.
Yeah.
It'd be right there, wouldn't it?
Yeah. So, and the other thing is that the primary venous insufficiency, it's kind of comes on over a long period of time. It's usually fairly subtle, but the symptoms can become severe. But it does just progressively get worse and worse with time, and at some point it becomes symptomatic enough for people to take note and find help for it.
And some of you may do that by going to our website. That's veinclinicsofhawaii.com, veinclinicsofhawaii.com. I told you earlier I'd give you a phone number, and I will. You can call them up later on, call the Honolulu office, and they'll get you directed to the right office. But there's also a myriad of things. All the things we're talking about, you can click on the website, and it's getting better and better. And the more often you click on it, the more you're going to learn about this, including the podcasts, which I think are really terrific. And more than anything, and Dr. Juliff, when we met, it was about educating people, not just about what they've got, but what are the options. There seem to be a lot of different treatment plans that you're employing to determine which is the best for each individual patient. It's not just a vein factory.
Absolutely. Yeah, and I think that's the key to, treating venous insufficiency in a proper way is, taking each patient individually and figuring out what is going to be the best treatment option for them that's going to correct the problem and achieve their goals. I
take it that there is a significant measurable difference between primary and secondary venous disease.
There is, yeah. Secondary, although valves eventually do fail, they fail in both forms, but the primary problem is not that the valve is failing as it does in primary venous insufficiency. So there's some inciting event that creates problems within that vein that is going to lead to valve failure and other problems. And most often that is DVT, deep venous thrombosis.
Which is, if you've been watching television lately, some of the darling medicines have got a hold of that and making us all know what some of these things with initials are. This is a real lurking problem.
Yeah. It's been a good thing. The media has sort of adopted DVT as an initiative, which is good because I think a lot of people didn't recognize the when they maybe have had it or the initial symptoms, the initial signs. And I think people being more aware of it has saved lives. I mean, there's no question about that. Not only within the general population, but especially in hospitalized patients, we're doing a lot more to protect people from DVT in the hospital, which is a hotbed for that.
What about air travel especially gets competitive, and we're seeing more and more competition. When business is good, it's very, very good. And most everybody wants to have I don't want to say bucket list, but a bucket list. They want to have something that they want to do while they still can. And I'm afraid that a lot of these people take off on trips, not realizing that they're just one away from having a big issue.
Well, that can be fatal.
Yeah.
Yeah, there's no
Yikes.
question about that. DVT it's not just the blood clot in your leg, which can be detrimental enough, but it's also the potential for it to develop into what we call a pulmonary embolism. Some of that clot breaks off, goes to the lungs, and can be fatal. In many cases, it's fatal. So anyway, DVT is the primary reason, the primary inciting event in most people with secondary venous insufficiency. Why does that happen? Well, the blood clot occurs or happens in a vein, and a lot depends on where in the venous system it is. Typically, the higher up it is, the worse it's going to be. But the first thing that happens is that it clots the vein completely and it stops flow. So that's never a good thing. However, our body is an amazing thing, and usually when blood clots in a vein, the body finds a way for blood to get around that blockage. But it's never as efficient as, the primary vein being open and functioning.
Yeah, it also dawns on me, and by the way, you can check this out particularly at veinclinicsofhawaii.com for sure. But Doc, I think that maybe this is, it's really I know it's scary, and that's fine to be a little bit scary. But by the same token, I don't think people, when you say the word clot, most of us think, well, I cut my finger and there's a little clot there, and that's good. But from what I understand, and look at some of the things on the website and looking at some of the things that you've shared with me before, is these clots that we're talking about in your veins can be very long. They're not just a little thing like on your finger. They can be, so anticipating a piece breaking off is not pie in the sky. That happens.
Oh, it does. Yeah. And like you said, it can be a fairly large chunk of blood clot that then makes its way up through the heart and into the lungs, and that's why it can be fatal. Because
there's a couple of places where it's going to stop, maybe, but if it doesn't, the further up the food chain it goes, the more dangerous it is. The ultimate
location, the final resting spot is in the lungs.
Are the traveling practitioners and flight attendants and others up to speed on this, or can they be? Do you think that some airlines try to make their folks understand, hey, look, if this happens, this person might be getting this. You need to do this.
Yeah, I don't know that for a fact, but I can't imagine that they don't talk about that. Because DVT / pulmonary embolism is such a common event, it could be a potentially common event on an airplane, and can be devastating.
Yeah, but I guess my real question is that I'm gathering a lot of this can happen as a result of being on that airplane. But when you get off it, get in the cab, go to the hotel, from what I understand, a lot of people get in trouble at a hotel.
Right. Yeah. They're sitting on a plane, and because of the immobility, sometimes dehydration, many people have a genetic propensity to develop blood clot, and they don't even know it. They're sitting on a plane, they develop the blood clot, and then it doesn't break loose and move until they're up and around and active and doing other activities.
When that happens, Dr. Julep, are you likely to get them again? In other words, if you've got one and get treated, you had the symptoms, somebody figured out what you are and treated it, I'm guessing if that happened, guess what? There's no guarantee that's not going to happen again.
No, there is a higher incidence of DVT once you've had one, definitely. So the clot occurs, and it impedes flow for a while, but with time your body starts to break the clot down, and typically we start people on a blood thinner.
Mm-hmm. We've all heard about that, seen some of that on TV.
Yeah. So the blood thinner really is not to dissolve the clot, because they're the standard blood thinners that we take aren't designed to dissolve clot. Some medication is. Blood thinners in general are not. However, the main thing that the blood thinner is doing is making sure that the blood clot does not get bigger.
Okay.
We don't want it to extend.
I got it. But also, isn't there a danger when you start taking blood thinners? There are other things that can happen, side effects, like you bleed for longer or more or quicker or it's hard to stop.
Yeah. Well, yeah, with a blood thinner, your risk of bleeding definitely goes up.
Yeah.
But you have to kind of, weigh the risks and benefits of anything. And if you've developed a DVT, you really need to be on a blood thinner. But the DVT itself initially creates pain and swelling. So that's one. Those are the two of the main signs of DVT in the leg. With DVT, with the symptoms of DVT as opposed to other forms of vein disease, it's a fairly it is a very sudden event. So and typically we feel pain in the calf or in the inner thigh. And also swelling. So those are two symptoms that you have to pay attention to.
So here's my advice. You've seen some great things around the coffee table at work and how to recognize a stroke and all of these different things. It'd be a pretty good idea if you just looked up DVT or when next time you're in Dr. Juliup's office, find out about that. I'm not saying that you can prepare for it, but you can certainly prepare to try to prevent it.
Yeah, and to know when you have to be concerned.
Yeah. And if you're not like I do, religiously wearing your compression garment, not socks, they're garments, remember. And if you're not doing the pumping of the legs, and even though they used to say feel free to walk around the cabin, they don't say that anymore.
They don't encourage
they don't want you. No.
They don't want. They don't want you in their way.
But you should anyway. Just take at least one walk an hour.
That would be a good rule of thumb, no question about it. So with time, the body, like I said, starts to break this clot down, but it's the minority of the time that the body is able to get rid of that clot completely. So over a long period of time, we see evidence or we continue to see evidence of blood clot being in that vein and having some negative repercussions.
Just out of curiosity, because we don't have time to fully go into the ultrasound equipment and things that you use diagnostically, but I do know that can you keep an eye on a clot or an area of a leg through an ultrasound, and maybe you notice that and you tell a patient, look, there's some clottage here. Next time we're going to take a look at it. We want to come back in 3 months and take a look at it.
Oh, we do that. And that's very important. We monitor people. If somebody comes to us and they have had an acute DVT, it's not only important to see what that looks like at that moment when they come in, but we put them on a blood thinner. We have them come back. We make sure it's not extending, and then also over a longer period of time, we see how the body, or we monitor how the body is handling that clot. That's something, as the body breaks the clot down, then we hope that there's going to be some blood flow restored through that vein. We call that recanalization, for the blood to start going through that vein as the blood clot sort of resolves and contracts and becomes a little more fibrotic. But it will never, if there's remaining clot, even though the body has broken down a fair amount of it, it's still going to continue to impede flow.
Gotcha.
It's not going to be a normal amount of blood flow.
So sooner or later, if it's significant enough, won't that blood that needs to get through there just find another way to do it?
It does.
Yeah.
It does.
That's a blessing, isn't it?
It is. Yeah, there's no question about that. It definitely is. But it's still not as efficient as a normal functioning vein that was there before. So what happens to the blood clot? Well, the remaining clot then attaches to the wall of the vein, and it becomes fibrotic. With time, it becomes very tough.
Is it less likely to break apart when it's that tough?
Yes.
Yeah. Okay.
Yeah. So that's one of the good things.
If there is one, some good here.
But the most important thing is that fibrotic clot that is now attached to the wall, not only it's there and it's impeding some blood flow, but it also creates kind of an inflammatory sort of environment, and eventually it's going to affect the valves.
I was going to ask you something, and I think you've covered this before, but our audience is ever changing and growing. And by the way, if you are like that, and who are these people? I'm Mike Buck, as you know. This is Dr. Randall Juleff. He's the medical director of Vein Clinics of Hawaii. 4 islands of service to you. And this show is being brought to you by Vein Clinics of Hawaii at veinclinicsofhawaii.com. And if by now you're curious and you want to get an appointment and get somebody to talk story with you, no obligation, call 427-5565. That's 427-5565. We're talking about these clots and things, and when you said vein, it made me think. I mean valve, it made me think. And that is, do clots usually start around the location of a valve, or do they start somewhere on the wall and then grow into a valve?
They often start right around the area of a valve,
which is a doggone shame because we want to keep those valves in good shape.
Yeah. It's I guess it's ironic, that it starts there and it ends there too, as the valve fails.
What are maybe some of the, I might be jumping the gun here a little bit, but I'm anxious to find out with all of these things going on, these clots, when you discover them, how do you treat them?
Well, when somebody comes in with an acute DVT, obviously we do an evaluation and we start them on a blood thinner. Now, in the past, all of those people were admitted to the hospital. Mm-hmm. They were admitted to the hospital. They had to elevate the leg, and they started on an IV drip and heparin, which is a blood thinner. But luckily, most of the time, we can treat people as an outpatient. Mm-hmm. So, they're a little more comfortable. It's nowhere near as expensive, from a healthcare dollar standpoint. And a lot of that is due to the new, all those commercials that you see on TV about blood thinners. Some of those new medications are good. Mm-hmm. And so it has allowed us to be a little more mobile in our ability to treat DVT again in a less tedious sort of fashion.
Yeah, one thing we might reiterate here, and we don't do this often enough. Vein Clinics of Hawaii, 4 locations. You're an outpatient. I mean, you hula in, you hula out, and that's. You may say, well, gee, my mom was in the hospital for 2 weeks. It cost $1 million. How come it's so expensive? I'm not going to the hospital. Well, duh. The equipment's better. The pain is less, and the treatment is a lot less invasive than it used to be. So, from what I understand, and this is my own personal experience, and many of you out there too, pretty much if you go to a qualified vein surgeon, you go to Vein Clinics of Hawaii, you're not going to a hospital bed. You're not going to be spending the night. You're out of there.
Right. Yeah. Essentially everything that we do anymore is done in the office. Everything that we do is very minimally invasive. We don't make a lot of incisions anymore. We certainly don't do vein stripping anymore. It's gotten so much easier to treat patients, not only for us, but also for the patient. Yeah,
I'm curious about another thing. Somebody else asked me to do this the next time I could remember, which I guess is now. And that is that, I do know the structure of the clinic. When somebody comes to you, they fill out a patient information form. Your staff goes through the categorizing of what type of discussion do we have to have with this patient. Are there times when they have to do something venous when somebody is in the hospital for another reason? Somebody's in the hospital, blunt force trauma, and they notice at the same time, hey, maybe they do an x-ray, maybe they do an ultrasound. I see them in emergency rooms now. Maybe somebody's got a vein issue. How often does a venous guy have to go to a hospital where somebody is hospitalized for some other reason to treat them for a vein disorder of some kind?
Well, not very often. Because,
which is good.
Yeah, that's good because they're for the most part, aside from DVT, which is, an important and acute sort of problem that can happen within the venous system, there aren't a lot of other real urgent sort of things.
Okay.
And for the most part, doctors in the hospital can treat, the urgent type things that might happen with the venous system. But though people in the hospital, and especially, trauma patients, cancer patients, people who are there and immobilized because of lung disease or on the ventilator. I mean, all of those people are very, very high risk for developing DVT, and that's why one of the good things is that we've gotten much more conscious of that and much more proactive in doing things prophylactically to avoid DVT from happening in the hospital.
Yeah, that's good. However, That doesn't mean, and how many times you hear, particularly back in the day, when grandma would fall down and break a hip and be hospitalized, and the next minute, she's got pneumonia and doesn't come home.
Right.
And I mean, these are all things. So I'm guessing that there's some venous conditions that are aggravated by the fact that you're in the hospital for another reason.
Sure.
So when you get out, you should see your vein guy.
Yes.
Yeah.
Definitely.
Yeah.
So what are the symptoms of secondary venous insufficiency? And they're very, very similar in many ways. And that is, we see pain, swelling, achiness, muscle cramping, et cetera, all of those things that we listed before. With respect to the superficial signs, it's going to be less often that we see things like varicose veins, because often this patient didn't have chronic venous insufficiency before. They had, again, an acute event, a sudden inciting event that created, the DVT and the valve failure. And all of that happens over a much shorter period of time. So usually varicose veins and superficial veins are not a part of the picture. They are more likely, however, to present with chronic swelling and skin changes. All the skin changes that we've talked about before, the discoloration, the thickening of the skin, and that type of thing. We see that much more often in secondary venous insufficiency. And then also the threat of ulcers that may heal but recur or become non-healing, et cetera. And all of those things kind of put together, we refer to that as post-thrombotic syndrome. That patient,
I've heard that. I wondered what that was.
Who developed a DVT now has fairly advanced venous insufficiency because of that, and all of the things that go along with it. That's a patient that we're again referred to as post-thrombotic syndrome.
Interestingly enough, and it may come as a surprise to some people, say, "Gee, I didn't realize that I had this going on." And you've often said, and this is folks, one of these sad stories about venous disease. It's very, very cruel because it sneaks up over a long period of time. It's sort of everybody's back burner, right? Until there comes some symptom that says, whoa, you got some venous issues here.
Right. Yeah. And that's why, especially in primary venous insufficiency, again, where it's occurring over a longer period of time, it becomes it becomes easy to ignore the symptoms. Number one. Number two, it becomes harder to recognize the symptoms because they've come on over such a long period of time. It's a very gradual onset. People tend to live with it and don't do anything about it until the symptoms are very bad.
One thing that we've noticed, and that may be a problem because, it used to be such a horrendous deal, but you would go because your symptoms were so bad you couldn't stand up. But right now, I mean, when you get out of a treatment plan, you're pretty much okay for a while. I mean, visually there's some things that take to go, a little way around. But maybe it's not something that you don't get as often as you get a haircut, but maybe you should think about getting it looked at every now and again or often.
Absolutely. And a little bit depends, with respect to that, it a little bit depends on the extent or the, complicated status of the original problem. People who come in with complicated issues, they need more follow-up. They need more attention and observation.
When you get together a treatment plan, I do notice, and we've had patients in, and we have some great patients coming up that you'll hear on the show real soon. We get these folks that become way more educated, and isn't sort of what we're doing here a way to say, look, don't be just putting on a long sleeve T-shirt and covering up your legs. You got to do something about these things because they're not going to go away.
No, they're not going to go away. And more importantly, it's just going to get worse with time. So, with respect to venous disease, it's not like we can change our diet, change our activities, exercise more, stay away from sugar, et cetera, et cetera.
Yeah, the old standards don't apply.
No. They're just going to get worse with time.
Well, listen, my friends and neighbors, we certainly hope you've learned something. We got a bunch of stuff coming up, and I really want to urge you to visit Dr. Julip's website. Vein Clinics of Hawaii on the Big Island of Kauai, Maui, and here on Oahu. Some great things going on there, and also it is a fun place. I know we've been talking about a little bit of gloominess here and some procedures. But there are a lot of other things that are cosmetically good fun to do, and it's just worth a look at. So you go to the website and check it out. And also, if you want to call up, I'd suggest you call the Oahu number. It's 427-5565. That's 427-5565. And you'll talk to a professional. They'll get you in there, and they'll get you lined up to see the doc and find out what you can do to have yourself a much better time of life. So thanks for listening. Tell everybody that we're here, and we'll be seeing you again next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com.